All right, well, let's go ahead and get started. It's great to have you guys here for our colloquium today. And we're really delighted to welcome Robyn Axel-Adams, who's a longtime colleague and good friend. Robyn is the manager of the Fairbanks Center for Medical Ethics. And before taking this position, she worked at IU Health Ball Memorial Hospital as a staff chaplain. She's an ordained United Methodist clergy person, and she completed the Fairbanks Fellowship in Medical Ethics in 2011 and 12, where she focused on developing a curriculum for teaching internal medicine residents about medicine and spirituality. Her current work is in advanced care planning, serving as a resource for IU Health and an educator for advanced care planning facilitators. She's a fierce LGBTQ ally, an NPR nerd, and loves to be outside. She's married and has two children, and hopefully this is still up to date, 2 cats. Take it away, Robyn.
Thanks, Lexi. Yes, everything was still up to date. So no more cats. That's the important thing. All right, thanks everybody. So I'm going to share today about my values grant that I have received from you all 2 years ago, which is wrapping up. And so the grant that was applied for was called the Facilitated APC Conversations, Education, and Empowerment. So when I wrote the grant, I had 2 aims. My aims were to enhance the skills of IU Health team members. And then I had received some money previously before the values grant of a proof of concept, a little bit pocket of money. And in that, I was able to be in 3 outpatient clinics. And my hope had been that with this grant that I would stay in 2 of the 3 outpatient clinics to sort of continue to test that, do some tests of change, and that then we would create a model of sustainability to be able to potentially scale this up across the system. And so these were I just kind of pulled this out of my grant. These were my hopes for and my plans as I had my year 1. A lot of it began around finding partners and starting to offer respecting choices courses, which I'll talk about in a minute, with my also then becoming a respecting choices faculty person. And then year 2, just going a little bit deeper and broader and wider. So aim 1 was to enhance the skills of IU Health team members. So our goal was really to think about moving this more upstream in the outpatient clinic, to think about how we could help patients have conversations before they have reached the crisis point. However, when I was offering to teach IU Health team members, I did not limit it to just people who are working in the outpatient clinic. So I'll go through my list in a little bit of who was there, but I had team members that were both outpatient and inpatient who participated in the training. And the training that I'm talking about is that we chose to go with the Respecting Choices model. If you're not familiar with Respecting Choices, they are based out of La Crosse, Wisconsin. They're sort of one of the gold standards of advanced care planning conversation. The one that has probably been around the longest. There's a lot of really great ones that have come out since then. But one of the things, there's 2 pieces that I liked about Respecting Choices is that one is that they acknowledge the fact that there's different kinds of conversations to have depending upon where the person is at in their disease process, or maybe even not a disease process yet. The first steps conversations are conversations that you and I could have. And then the second is that they provide training to their facilitators. They don't just have a guide and say, here, go do something. And so in order to be able to be considered an advanced care respecting choices facilitator, you have to go through one of their trainings. I had worked some through my proof of concept and through some other funding, been able to be an instructor for each of these steps. So we didn't have to send people to the national courses, which is a great financial benefit. So I'm able to teach each of these steps of the conversation. And so I offered all 3 courses. I offered first steps, next steps, and advanced steps training. So in the first steps, I had 85 team members in 11 courses that took the course. I had offered a 12th course, but the numbers were low. And so just was able to offer the 11 courses. 16. So let me back up also. The way Respecting Choices does their training is that they have what they call a core course, where it's the same kind of in every 3 steps of the conversation. And then they have what are called the intensives. So first steps, next steps, and advanced steps are the intensives. You can do an intensive or the core and next steps. Like you don't have to do it in any particular order. However, I found when I did one of my initial trainings where I did a core and an advanced steps class together, that was too much in one day to try to introduce the concept of advanced care planning and then go into what are those advanced steps conversations like. So I did some, test of change. That's what you do when you do some early work. And I made every single person go through the first steps course. So before they were allowed to take a next steps or advanced steps course, they had to take a first steps course. They could stop there. They did not have to take any of the other courses. So when I say 16 team members took advanced steps, that is out of the 85. And the 22 could also be part of the 16, and they were definitely part of the 85. So we had people, and I can go back and look, I did not include that here, but we had people that took all three, and people that took two, and then people that took just one. So the advanced steps course is geared towards people who are post eligible, and it really helps you facilitate on how to have a conversation around the post. If there's questions about what that is, we can talk about that later. And the next steps are people that already are at the beginning or middle stages of a serious an illness, and they will probably have complications. So that's how many people around the IU health system were trained. And so these are some of the departments. I was able to train people in the congregational care network. Population health was one of my bigger requesters for training. They are now called value-based care. The Grace Clinic, which the Grace Clinic for IU Health is our Medicare clinic. Some people at the Cancer Center, the Indiana Cancer Center. The only physician that I had take the course was from the Neurology Movement Disorder Clinic. Community engagement, one of their social workers took the course. And then I did have, so those are all outpatient. And then inpatient, I had the opportunity to train all of our chaplain learners, chaplain residents is what they are called. So our chaplain learners, that was incorporated in their curriculum, and social workers and case managers from some of the other hospitals. So kind of a nice mixture of outpatient and inpatient. So I had them take lots of surveys, and not everybody took a survey. Of course, it had to be. It was not required in order to participate in this. But before the course, I asked them to think about what are their fears or their concerns. And so most of them just, I worry about how to talk to people about this. What I heard over and over again is that in my role, I'm expected to have these conversations, but I don't know how to have them. So these were what people in their survey said before the course. So they were also asked to do a pre-course self-assessment, and 14% had received, of all of the people that filled out the assessment, so 42 completed the assessment, 14% had received some sort of training before. And I asked the question, what kind of training? And most of them were, the people who said they'd received the training before had been chaplains who I had done like a small didactic with them before. So just a small, tiny little handful had done any other sort of training. These numbers here are on a Likert scale, so 1 to 10, obviously 10 being the highest and 1 being the lowest. So motivated, confidence, and do you feel skilled in being able to promote the conversations? So I'm going to walk through just a little bit about the evaluations. I'm not going to read these to you. I can always send my PowerPoint later, but overall, in that first steps course, people thought it was very beneficial to them. I appreciate this person who said that she appreciated the reminder of being a good listener. And now they kind of felt confident to be able to answer questions and be able to help them through their advanced care planning. So the next steps, again, those were patients that are in kind of in that early to middle disease process. And they found it very helpful. And then this is, I think the advanced steps is the one that it's my favorite course to teach, advanced steps, because the post form is a form that is so important. And also so often physicians, no one knows how to have conversations around this. So I think that the training around this is really good. And so, it was really helpful in order to people to understand the post forms. And I will say that more and more of our inpatient social workers are being asked to help complete the post form, and then the doctors sign them. So to being able to help them know how to fill this out was very appreciative. So we also did then, I asked them to do a post-training self-assessment. Now, these are not going to be exact. I don't know if the people who filled out the pre-self-assessment and the post-self-assessment are the same people. The numbers are different, so I know that they're not 100% the same people. But I'm thrilled by the increase in the motivation, the confidence, and using the skills. I think that it shows that the training has high value when you look at how. So I'm so sorry, I should explain. These numbers in parentheses are the pre-training self-assessment, and then the numbers that are not in parentheses are so then these numbers are the post self-assessment. So the lovely increase, I think, lovely increase between post self-assessment and pre self-assessment. I also asked them at 3 months to give a kind of an overview of where they're at, where their assessment was. And I think that we can see that it's still challenging to get these conversations in. Some of it is around time. Some of it is around what will happen in the conversations, and some of it is around patients' willingness and to be able to have these conversations. And so none of this is surprising to me. And I don't think that people who work in advanced directives or advanced care planning, this would surprise anyone. Especially the time about the question about time. These people who have taken the course have not been given 100% dedicated time to be able to have these. These are people who are still fitting advanced care planning conversations into their day-to-day life, and so we know, or day-to-day work life, and so we know that having these conversations can take time, and they don't have 100% time to do that. All right. So one of the other things I asked them to do was that I said, hey, once you have a conversation, can you please message me, text me through the private means when you've had that conversation, so I can document if this training has been helpful to you, and then and then I did a review of the documents. So I have only received comments or been told about 92 different conversations or document reviews. And I put document review because 75 of the 92 come from the Grace Clinic. What the Grace Clinic would often do is go through and make sure that a patient had an advanced directive, and then they would message me when they did their own review about the patient, and they would message me that they had reviewed it. I wasn't sure whether to include these people, this group in my database, but I went ahead and included them. 18 of the 75 were conversations. The rest were chart reviews. However, I know that the chart reviews were helpful for them because they were able to identify gaps in some of the advanced directives. I also would review every single advanced directive that the Grace Clinic had said that they had reviewed, and I found gaps as well. And so for example, I found a post form that the patient had not signed. And so technically that's not a legal document. So I encourage them to, next time they visit the patient, to go ahead and have the patient sign that post form. We had post forms that were in the patient's document that are in the patient's chart that were not signed by the physician. And so I said, the next time the physician sees them or the nurse practitioner sees them, they've got to sign that post form, and then get that newly signed post form in their EMR. So I think that the review was a helpful thing to do. It's just not quite the conversation that we had intended. So I will say that my return rate of did they have conversations is low. And my guess is some of that is because they're not having some of these conversations as was reflected upon sort of our 3-month review of where are you at now that you've had this training 3 months later. One of the other pieces that I had as I was talking about empowering and working with IU Health team members is that one of my goals, and we did hire, part of the grant was to hire Respecting Choices as a consultant for us. And so Respecting Choices has kind of 3 different levels themselves. They have They have facilitators, which are the people that can have those conversations. They have instructors who can teach the courses. And then they have faculty, and the faculty are people who can train instructors. So I became a Respecting Choices faculty at all 3 levels of first steps, next steps, and advanced steps. So now that means that if we want to have more people that can be instructors, I can train them. We don't have to go to the national courses to do that. In order to help with this, I recruited 2 new first steps instructors. My goal had been to recruit more. Again, the timing level and the interest level. So I was able to recruit these 2 amazing people. Aaron is a social worker with the Central Indiana Cancer Centers, and Dustin is a chaplain with the Congregational Care Network. And so they are both deeply invested in this and have already helped me to teach 1 course. And we have another course set up in September that they are geared for to help me teach. So it's nice to be able to have some extra instructors who can teach these core and the first steps course with me. I'm going to jump to AIM 3 for a second, and because I'm gonna circle back to AIM 2, but AIM 3 is not an AIM I actually wrote in there. You might be thinking to yourself, wait, Robyn, when you showed that first slide of what your aims, there was no AIM 3. So AIM 3 is what I probably should have labeled everything else that I hadn't considered yet, and dedicated time. And so I found over and over again that when I would approach people about doing something, they would be like, well, Robyn, does this fit within your grant? Because I'd say, I have a values grant that enables me to do this. And people were so conscious of the fact that grants have sometimes very limited and structured guidelines around them. And my response was always, it will be fine. I know the people that are involved in this, and as long as I'm doing good work, they will be fine with it. It did help that Lexi Twerky and I would meet monthly, and that for a time being, we were in our offices were on the same floor, and so there was a couple of times that I ran down to her office, and I'm like, "Hey, this new thing just happened," so I know I had her support. But truly being able to have some time dedicated to doing some things and being able to think outside the box was kind of one great outcome that came from it that I hadn't anticipated. So here are some things that I did that were sort of not anticipated, but I was able to do. I did some community trainings, and I worked with the Congregational Care Network, who helped me get connected to this assisted living community. So I did a training with them. Community outreach does lots of health fairs and such. And so I have provided them with information packets that they can hand out at their outreach events around advanced directives. I have been in conversation with the 100 Black Men organization. I went to one of their meetings and kind of introduced myself to start gaining the trust. And they were having a colloquium with the Alzheimer's Association, and with being unprompted, one of the caregivers at the Alzheimer's Association said how important having advanced directives was, and so they are looking at in the fall. Having another colloquium around just getting kind of your ducks in a row or ducks in order around lots of issues as you grow older. And so they have, I have offered to be a part of one of their panels. And I also acknowledge the fact that if we want to make sure that they just get the best information they can in the way that was best for them. So I am a resource if they would like it. I presented at a local food pantry. They always have little gatherings before the food pantry opens, just to kind of let people know about community resources. And so I was able to talk and meet with the people that attended that. And then I was invited to speak about advanced directives and advanced care planning to the ECHO program, the Indiana ECHO program, which I had to learn about, but it's a program that is statewide, and there are providers from all over the state that attended that meeting. And they, when they meet monthly, they always have a didactic session. So I was the didactic session for one of those. The biggest thing that I have done is I have done tons of other training for IU Health team members. And so not everybody can attend the one day, it's a full day advanced care planning training. That's fine. And so over and over and over again, I would go and I would talk to different groups, meet with them, and just talk about advanced care basics, post basics. And so I also appreciate, so just forming new relationships. One of my new learnings was that I was up at the up at IU Health J. and the ambulatory council, and they started asking me questions about Ohio advanced directives. And I underappreciated how close we were to Ohio. And so I had to reach out to my colleagues at Parkview. That Parkview has an advanced care planning department. And so I reached out to them and asked them questions. I then had to reach out to our legal team to see how we are going to address those issues. And so we were able to get some answers back to them. But the other thing that I liked about that was that IU Health is about to open a hospital in Fort Wayne. And so we need to start looking about and being proactive about what are we doing about advanced directives from Ohio, because we will have so many patients potentially that live in Ohio that come to Indiana or that and back and forth. And so we started to help our legal team think about that we need to be proactive as we are about to in the future open a hospital in Fort Wayne. And I have more speaking engagements kind of coming up. Another thing that happened, is that I was able to create some resources for our team members and for patients. And so I created IU Health has a team portal. And so I have an advanced care planning page on the team portal. I then also created physical resources that can be handed out to patients that can be ordered through the brand center, which is an IU Health's kind of printing department, or I can also get them to people. I was able to provide a lot of these resources to people who would attend the training from the grant. I was able to buy a lot of resources just to be able to hand out. The other thing that I became, and I still have, is just people will email me and ask me questions because they don't know where else to go. These are questions that I have received just this summer. And some of them are super basics, like, can I have a copy of the Indiana out-of-hospital DNR form? I don't know where to get it. Sure, you can. To asking me if certain forms are legal, to saying, hey, I was actually in a meeting and I heard someone say, hey, we need to create something to help people know how to put the document in the right place in Cerner, because that is a problem. And I stopped them and I was like, we don't need to create anything. IS has already created something. And so I was able to provide them the job aid that IS had already created. I also freshly received an email just yesterday that one of the people in one of the outpatient clinics, I saw the email chain that she had, and she had emailed probably 5 to 7 other people saying, I have questions about advanced directives. Can you help? Nobody was able to help. Nobody was able to help. And so she finally just reached out to the general email box at the Fairbanks Center. And she and I are going to have a meeting on Monday. And she says that her basic goal is to help, is hoping to understand the roles of the front desk and clinical staff and what roles do they play when patients submit advanced directives. Great. And so maybe there's a potential opportunity that I can then do some training for their team. So 99.9% of these people have reached out to me directly. We got this first one by just someone emailing the general questions. And so I'm excited to be able to be a resource for people to ask their questions, because that hasn't happened at IU Health. We just haven't had any one kind of entity that knows and can answer the questions. I have been working also on electronic signatures for some of the our forms, because that is now legal by the by Indiana legislation. That's a whole we're still working on that. My vice president, Amy Martin, owns these two these two policies. And so I was able to make sure that they were in alignment with the current IU or Indiana legislation. We did not actually have an out-of-hospital DNR policy within IU Health. And so I worked with RISC, and we took the post policy and we added the out-of-hospital DNR piece to the post policy, and we changed we changed the policy to be called the portable orders policy. And so I was glad to be able to add that and contribute that. If any of you ever worked at IU Health, maybe up to 5 to 6 years ago, and sadly even in the clinics today, there is this massive, the Indiana Department of Health created a massive 13-page document, which was supposed to help people understand about advanced directives. It did not. It was so complicated and confusing. However, it was the only kind of educational piece that was out there. And so but it became out of date. So the Indiana legislation around advanced directives changed dramatically in 2021. So therefore that big old clunky document was out of date. And so I found how people were getting it within the IU Health system. And so I got that taken down. However, many clinics had just downloaded it. So I've been trying to find those, but then the clinics who had used that resource that they where they could just go within the IU Health Computers networking system and download it. They were then, well, what do we do now? What resources do we use? So I met with lots of different departments to talk about, well, we have this that I have just created, some of the patient references that I was just talking about. Another thing that we're working, that Dr. Martin and I, Amy Martin and I are working on recently is we've approached the Department of Health and asked them to change the wording on the post form. And the Department of Health is the one that owns that form. And so we have asked them, this is the Illinois form. I took this directly from the Illinois form. We have asked them that if they could change this box to let the people who are filling it out know that if someone says that they want CPR attempted, then they also have to say that they want full treatment. We had too many times when there was no CPR marked and the patient wanted full treatment, and those are in conflict with each other. And again, I can talk more about the post form if that's a form that's unfamiliar, and that would be helpful later. I've worked really hard to become involved in some networking groups. I am a part of the Indiana Patients Preferences Coalition. That is the group that helps move forward legislation around advanced directives and post. I have recently become part of the National POLST organization. So POLST is the name of the national group that kind of gives some oversight and guidance to some standardization around the post form. And so I'm a part of that organization now. I attend Respecting Choices meetings. The faculty get together quarterly. And I've recently been able to join an advanced care planning directors networking group with a couple of other hospitals that have advanced care planning directors and managers, and that has been so extraordinarily helpful. And I've really enjoyed kind of being a part of that networking group. I've learned lots of lessons from the last 2 years. And so these are some of the lessons learned, and we can dig into those more if you would like to. Okay, so now aim 2. Aim 2 is to stay within 2 outpatient clinics and then establish a model of referrals that can be scalable. So I did stay within 1 clinic. Let me back up and say I stayed within 1 clinic, and the second clinic was a pulmonology clinic that was in Lafayette. I live on the east side, the sort of the central east side of the state, and I will just be honest that it became tiresome and burdensome to travel to that clinic an hour and a half one way each week. So I tried going once a month, and the referrals just kind of dropped. There was not a lot of, I shouldn't say there was not a lot of referrals in the first place, but this just did not feel like it was a valuable use of time to stay in that clinic. They knew that I was still available for referrals, but I've not gotten any referrals since I have stopped attending. So that's always an important thing to keep in mind, is presence does make a difference. But I have stayed in 1 primary care clinic up in Muncie. I go there once a week. And even though I am there, I still don't get tons of referrals. And so my first referral, so my grant started in July of 23. And in that 2-year time frame, I have had 27 referrals and 5 conversations. And so I had started there because of my proof of concept in May, and I had had 25 referrals just even in that first year. So there's been kind of a shift, and one of them is that a provider has changed and moved away, and one of the providers that had provided some referrals was one that left. And then the other potential reason for lack of referrals is something that I just had one of the providers say to me last week. As she said, Robyn, I have so many patients I should refer to you, but the patients are so uncomfortable about having some of these conversations. And so I did a little bit of coaching with her. I said, well, first of all, if you normalize it and say how important it is, I think that helps. Normalize that it's a conversation that any adults can have. It's not that you're having it because there's any end of life issues. But then also make the referral, and then let me work on making connections with the patients. The other thing that I learned is that when I talk about referrals versus conversations. And so I would write a letter to the patient and just say, hey, your doctor has referred you, and I would like to have a conversation. And then I would call them. And what I discovered, or what I came to appreciate over time, is that I didn't want to limit their ability to receive resources to be based upon my talking with them. So when I started, I did more than just then starting to send letters. I would also send them resources so that when they receive my letter, then they would receive a healthcare representative form. They would receive a conversation guide that was created by the Conversation Project. That if they wanted to have these conversations on their own, they certainly could. So I don't know how many of those people took me up on it or did anything with the documents, but I did not want to have their lack of meeting with me be the lack of reason for having referrals. So part of the idea, though, was to create something that was a model of sustainability. And so this is why I saved it to the end, because I feel like this is kind of for me, it's the culmination, is that we have written a business plan. So we is myself, Dr. Amy Martin, my vice president, and Dr. Lexi Torkey have written a business plan, which was just submitted this week to upper administration. Administration has really been supportive and pushing Amy on this, to do this more in the outpatient setting. And so we know we already have administration support. We just need to see whether there will be able to be some funding for this. So we have presented a plan to them, and we will see where that goes. We have also been working on doing something in the cancer center sooner rather than later, trying to take advantage of Lexi's current position within the cancer center as Walther supportive care person. And so I have met this past week with both of the service line leaders at the Simon Center Cancer Center to be able to start working with some of their patients. And then this is part of the lessons that we have learned, is that we have to be proactive and less referral based. I just shared with you how little referrals I'm getting, even though I sit there every week and remind the providers that I'm there. And so we're going to take a proactive approach, reaching out to patients directly, looking at when they have upcoming appointments, reaching out if they do not have an advanced directive in their chart already. And again, providing that patient upfront information that we don't want to not let them have resources because they haven't talked to a facilitator. So my hope is that we will start that in the next 1 to 3 months. We're working right now on providing some information for the service line leaders that they can then share to their providers to see who would be willing to participate in that. So I'm excited. I've people when people would say to Lexi or to Amy, let's do a pilot. They could be able to say, no, we've already done pilots. We've learned lots of lessons. We're ready to start doing some implementation. So we're going to be doing some different phases of implementation. So I want to circle back to my aims then. And did I meet my aims? So the first was to enhance the skills of IU Health team members. I did do that. My target had been about 150, and I didn't meet that target, but I think that the people that I trained are excited about it. And I still have people that are requesting training. I was able to stay at one outpatient clinic, and we did establish a model for sustainability. And again, that third aim that I threw in there, all other things that I never considered to write into my grant, I certainly did that. So that is my sharing of what I did through my Evans Center grant. I'm going to kind of stop there and allow for questions or dialogue. And I know that there's potentially some things that I threw in there that people are not even, like some of you may not even know what the post form is. So if there's any education you would like done, I can also do some quick education around that. So I will leave it at there.
Robyn, thank you so much. That was amazing. I feel like you've accomplished, what you set out to do and more. So that's just great. I'm going to open it up for questions and comments. And as you come off mute, please just introduce yourself by name and maybe say one line about where you work and what you do in your current role. And then we'd love to hear from you. And please go ahead and come off mute. It's a small group, so you don't have to raise your hand or anything.
If you're waiting, type in
great job,
Robyn. But that was it. I didn't really want to jump in just for that, but heck with it. Great job.
Thanks, James. I'll always take a great job, Robyn. Thanks.
I'll just say one thing that definitely resonates with my own experience is that, and this was way before I started an advanced care planning research project that we're about to wrap up. I went out and interviewed about 12 physicians, and they would all say 201, yeah, this stuff is so important, but we just don't have time. And so what you're finding among non-physician staff, or all staff, which just really resonates. They think this is a good idea, but they just don't know, they just can't get it done within the increasingly busy world of medical practice. One thing I am curious about is it sounds like there were people who would accept your information but didn't want to meet to talk. And I am a little surprised by that, because it does seem like, to me, it would be more appealing to have a conversation with someone than just to get some stuff in the mail, unless it was just like an avoidance tactic. It's like, yeah, send me something in the mail, as a way to sort of get out of the conversation. So I wonder what you think about sort of, you're trying to turn over folks from the referral to actually meeting with you for a conversation. And what do you think got in the way of that?
So I think, yeah, that's a great question of what is the barrier. I would love to then be able to go back and survey everybody and sort of say, what was your barrier from saying sure to the doctor? Because it was usually the doctors that would first introduce the idea. Most of them were in the Medicare wellness visit, because in the Medicare wellness visit, that's one of the questions you ask, do you have an advance directive? And would you like more information? And potentially the would you like more information is like, sure, I'll take more information. But then when they're offered a conversation, they're like, whoa, that's not information. That's like more than I bargained for. So I think that some of it is that messaging. The people that I proactively had conversations with were often the ones that actually had heard about from their doctor, and then were calling back like a couple of months later. So like I had a conversation with a family, with a husband and wife 2 weeks ago, and I actually got the message through like the phone line that just kind of, the general phone line for the doctor's office, and they're like, they remember their doctor talking to them that somebody could help them with advanced directives. Well, now they want to, and so I think it's also about planting the seeds. And respecting choices will tell you that like 50% is amazing. And so I don't have 50%, but that even for them, the acceptance rate of offering in order to have a conversation is 50%. So I don't think we should expect 90%. And then the other piece that respecting choices says that it often takes 4 to 7 invites in order for someone to feel comfortable accepting. And so the doctor introduces it once, I make that email, I make the telephone conversation. So I think that it's also, we've got to figure out ways to normalize it. How do we normalize it within the clinic setting? What kind of posters can we put up? We all probably have walked into an IU Health doctor's office, and there's so many little flyers that are up. And sometimes it's overwhelming, and sometimes something normalizes it. Oh, this is something that is okay for me to talk about, not. So I think that there's a multi-layered approach that needs to happen. And we've still got to continue to do that multi-layered approach.
I see Beth, you just come off mute. Do you have a question?
Thank you, Robyn. Being a fairly new chaplain, is what we're talking about, the post form, the advanced care directive form, that isn't necessary. The advanced care directive, is it true that it's not necessarily standard across the IU Health system? Because what we use here at North Hospital is different than what I used at IU University.
So thanks, Beth. The actual form. So one of the things that happened when the legislation changed in 21 is the Department of Health said, we are no longer going to create the form. The healthcare representative form is what you're talking about, Beth, is what I'm assuming.
Yes.
Yeah. And so the Indiana Patients Preferences Coalition created a form, and our legal team, IU Health's legal team, looked at it. And again, the Indiana Patients Preferences Coalition represents the whole state. And so we created a long form and a short form. And so we can have other conversations about like how the forms are, what your experience is different. But so both of those forms are out there. IU Health, in my experience, because there is no mandate about a form, which is fine. Both forms are being used, both the long form and the short form. And because there's nothing on the Department of Health's website, like I think people are also just finding forms. And they're still using old forms. I had a clinic just reach out to me 4 months ago. It's like, hey, Robyn, I think I heard that we're supposed to have 2 witnesses. Well, the form we're using only has 1 witness. And I'm like, yes, then you're not using a form that's legal. And so there's, I think, advantages and disadvantages for the Department of Health to not have something on their website. But also, because there's not one entity like the Department of Advanced Care Planning that is like able to shout it from the rooftops, like there is no systematic way of having forms within IU Health. Not that like creating this department will solve all problems because we are a complex system. But I think, Beth, that you have identified one of the really key pieces of what happens when you don't have like a source of authority for some sense. Like you will never see a post form. You will never see different post forms ever, because it is the Indiana post form and it has to be used. And this is the form that has to be used. But like I said, the new legislation allows any form. So yes, I guess you're right, Beth. Yeah. And Beth, one of the things, and I'll just piggyback off of this, that Respect and Choices works on is having conversations and including not just filling out the form. And so that's what people talk about when they're like, these conversations are too long. And because it's the conversations are about getting to someone's values and preferences, not just let's complete the form. Because we're so used to doing let's complete the form that we don't sit and help people have a conversation about what's important to them.
I found that as a chaplain, that I could use that form in my role as a chaplain to go into a deeper conversation. So the form was almost a gateway to a deeper conversation, which the chaplain has the joy of having the time to do that.
Well, and I'm excited that you choose as a chaplain to use the form in that way. I know that some chaplains are glad that at their hospital they don't have to fill out advance directives, because at every hospital there's different entities that are also encouraged to fill out the forms. So I thank you for what you do then for helping patients to have a conversation.
Hello, I am Kebaka. I'm a postdoc fellow at the family medicine department. Most of my work is centered around immigrants, Muslims, and in that space of having a better cultural and spiritual inclusiveness in public health research and healthcare. So thinking about the advanced directive, I was thinking along it would be very interesting to understand if you've come across any differences in uptake when it comes to different cultures and different religions. For example, in Islam, we have 4 main schools of thoughts that all have different views of advanced directives. Some say it's okay to have it, some says it's not okay because it's considered you are already giving away your life, when you should not give your life. So how culturally inclusive and culturally aware are those forms that you have?
That's a really great question. So I would say that the difference between the form and the conversation. So the form is not terribly, I would say there's a part of me that wants to say, well, it's not culturally inclusive at all. However, the thing that I like about the healthcare representative form, which is the main form, is that you can name someone who the purpose of naming a healthcare representative is if you don't have the ability to speak for yourself, who would you want to speak for you? And so I think that that allows lots of cultural flexibility, because in some cultures, maybe you don't, it's not going to be your mother or your spouse that speaks for you, but it's going to be a religious leader or something. And so I think being able to name who you want to make those decisions that may fall differently than what the Indiana hierarchy says, I think that helps make sure that our culture is respected. The conversations, and especially with respecting choices, there's a culture and religion question that's embedded in there. And so, we ask the questions of what cultural, what's important to you culturally that we need to be aware of, and what is important to you religiously that we need to be aware of. So when we have those conversations, those are questions that are embedded in there, because we want to make sure that a person's culture and religion are respected. I think that the other part of potentially of your question is that kind of what have I seen? And I'm just actually going to go back to the research that Lexi was talking about, that she just is working on, is that we did not have a very religiously diverse group, we discovered when we looked at religion. And we don't know why. We didn't ask people who said no, like why they would have said no. And so while Indiana and Indianapolis has a very much more diverse group of people that live in it, I don't think that we have successfully navigated connecting to some of those minoritized groups. I don't know, is that fair to say, Lexi?
Yeah, I think so. I mean, both in our clinical work and in some of the research we've done, we've had very small numbers of Hindus, Jews, Muslims. Pretty much most of the patients in our programs are either Christian or identify as having no religion. And so, yeah, we have a lot to learn, but there are a lot of good resources out there that about various aspects of advanced care planning or end of life care from the perspective of different religions and cultures. And so definitely if you, if you look for things like that, they are out there. And actually on the Evans Center website, about 2 or 3 years ago, we did a series of conversations where we invited leaders from various religious traditions to talk about the role of religion, spirituality in healthcare. And so there is one about care of the Muslim patients that may touch on some of these things. I think one other thing to say is that one thing we've learned that actually our former Vice President, Steve Ivey, always emphasized to me, and it's absolutely played out in our research, is that it turns out that just knowing someone's religion does not predict very much about their preferences or their approach to advanced care planning. So just being a Muslim or being a Christian doesn't really tell us much, in fact. There are a few other variables that are, one is intrinsic religiosity, and one that really affects decision-making is a belief in miracles. But we've, been surprised that you just can't predict differences based on just knowing someone's faith, because of course there are, fairly liberal Muslims and there are very conservative Muslims, and, same with all of the world's religions. So I don't know, Robyn, if you'd add anything to that, but that's been an interesting finding, and it's pretty consistent.
There have been, I mean, if you're interested in sort of some research that has been conducted, there have been a couple of studies that have successfully worked and been intentional about recruiting people of the Muslim faith. And so if you're interested in what else has been done outside of Indianapolis, there are some articles that I can pass your way.
Thank you.
Does anyone else have a question or comment? I want to say that I'm going to it would be lovely if you're willing to share your slides, if you'd send them, or even maybe a PDF of them to Gloria and she can distribute them. Sure. But I am really interested in this thing about post-form inconsistency. And in our recent study, we found a lot of inconsistency. In fact, one of our resident who's working with us, Ryan Lucker, is going to actually write that up as a number of people in our baseline study. And it wasn't we didn't exactly show them a post form, but we asked them about code status, and then we asked them about overall goals of treatment based on section B of the post form. And there were many people who wanted full code status, but limited additional interventions. And, it's just interesting to think about why people choose those, like we have a framework as clinicians in our heads that patients just either don't know about or don't buy into.
I would also say that our form doesn't help, by the fact that we don't label that very clearly, that you cannot have both, that our form sets people up to fail. And so the other piece is that one of the reasons, or I know I listed them very quickly, but one of the groups that I presented to is I went around to every region's, the hospice group in every region, and I did post education for them because they had an incident where they had a patient who had said that she wanted no comfort measures only and full code. And her son, they just had an incident that created some problems, and that they were trying to then, when they did their root cause analysis, they realized that one of the things they needed to do was provide post education. So I went around and so then they are going to be much more intentional about making sure the post forms, when they enroll a patient, are not incongruent. And when they did a chart review, if you're curious, Lexi, about the numbers, but when they did a chart review, like they found a handful of charts of post forms that were inconsistent.
And just one for everybody, since I know there's some folks on the call who may not, have all this medical background, but basically, unlike it's shown on TV, if you survive your resuscitation, you will wind up in the ICU on a ventilator. Like, that is just a fact. And so these, and I suppose really TV contributes to this myth where you'll have someone, he's coding, and they all rush in, and then 10 minutes later, they're lying in a bed with no medical equipment having a conversation, which is so inaccurate. But a lot of people see that and then mistakenly think that you can survive a code and be talking to people 15 minutes later. All right. Well, thank you so much, Robyn. Great work.
Well, thank you for the grant.
Yeah, I'm very excited that this is now, moving forward to a larger initiative, starting with oncology and then primary care. And I think it's going to, lead to some really great things. So thanks, everyone, for being here. Bye-bye.